Hello, my name is Ntounis. I'm a periodontist practicing in Fredericksburg, Virginia. Our practice is synergy periodontics and implants, and I'd like to present to you a simple periodontal bailout to a peri-implantitis lesion induced by restorative design. And many times we do get referrals to that have to deal with older restorations on implants, older implants, and the concern is, can we do anything to save that implant, or can we do anything to basically allow for a better environment around that implant? In this particular situation, the restoration in question is the the second premolar on the upper right, and you can see also the extent of that crown. It's made in a way to mask, at least that was the understanding I feel from the restorative dentists at the time. It was made in a way to mask the significant deficiency in soft and hard tissue around an implant. It has a subtle shape defect. The overall appreciation of the patient shows more of a medium to thicker biotype, really, with, of course, only exception in that particular area. And also, we have a patient here who has significant challenges in plaque control. There is significant accumulation of plaque and calculus in different areas. There are restorative designs such as the adjacent crown on the molar that are not extremely, they're not biologically friendly. You see the crown margin extending bifurcation. And also there is recession associated with the adjacent teeth. So the upper right is an area where there is recession, thin tissue, thin gingiva around the teeth, thin peri-implant tissue around that implant, and minimal zone of attached tissue and thickness of tissue on that implant. So a closer look in that area radiographically shows that thankfully there is significant thickness of buccal bone around that implant. So this is an implant that we would like to try to keep. That implant was placed about 10-15 years ago. Yes, it has gone through the sinus floor for a couple of millimeters. There is some thickening of the membrane associated with that. Overall, this appears to be an implant that is very much savable. Now, of course, the site preparation wasn't as adequate. So upon elevation of full thickness flaps, this is what we see here. You would expect that to be cement. I expected that the same also. Obviously, it's not the case upon closer look. This is part of the crown. The crown literally has a saddle design to it to mask that deficiency, and it's extending way, way apically. The amount of bone loss is rather minimal. A point that I'd like to make about my flap design, this flap design is a full split flap. It has a full portion on the very top, as well as a split thickness portion as we move further up. The reason for that is I always like to retain the privilege of me introducing connective tissue grafts or other type of grafts that need the split thickness bed. So obviously the issue here is the design of the restoration. And a very simple bailout would be, after of course consenting the patient that I would like to really touch this crown up, I would like to really change the shape of that crown, especially in that subgingival or gingival portion of that crown. Obtain consent, make sure the patient does understand that this may jeopardize the entire prosthesis. Of course, that is not as difficult as it sounds, especially if the patient understands that it's the crown that's the main culprit of the situation we're dealing with right now. And I use a high speed and a diamond. And before that, of course, I like to clean the area. And in my practice, we have recently introduced the EMS system, the airflo. It uses around implants glycine powder of 25 micrometers, and there is a considerable body of literature out there that shows that with the use of the proper powder, we're not introducing any surface alterations on the implants. This is a paper by Frank Schwartz, and also a different paper by another team of researchers showed that there is a significant reduction in biofilm comparing to hand instrumentation. So I don't use the traditional titanium curettes that you saw on the previous slide anymore. I like to use this glycine powder, and I also use Pref Gel EDTA for chemical disinfection of that area. After all that is done, And ideally, as a step immediately after the reshaping, this is the reshaping that has taken place on that particular situation. So with a high speed and a diamond burr, we literally just remove the ledge from the crown. We provide a better environment for that patient to clean. And you can see how this has been altered. And one could have been even more aggressive in this particular situation. Of course, polishing of this area needs to take place afterwards. This is a titanium scaler. You can see the amount of ledging that was previously there, and you can see how much different it looks on this particular slide after the reshaping of that particular crown. Now, is that enough? Should we just close right now and suture the area and let the patient go understand that, hey, you know what, we reshaped the crown, we disinfected the area, and you're good to go? Or should we do something better? And I think we should always provide the patient with a better outcome. And the better outcome is only guaranteed if we change the environment of that area. The gold standard for changing tissue environment is still the connective tissue graft. In this particular situation, I'm using donor side from the adjacent palate. I'm harvesting a free gingival graft of 1 to 1.5 millimeters in thickness. And I partially deepithelialize that graft on the areas that are to be placed under the flap. And I leave epithelium on the areas that I'm planning to leave exposed. So this is what the placement of the graft looks like on the recipient side. There is epithelial layers here. You can actually see it. This area is deepithelialized. That's where the split thickness flap of the recipient side comes into play. And we use polypropylene sling matter sutures to suture that area. This is a C170 polypropylene. You can see the areas of exposed graft here. This is the donor side. And this is how the area looks like 2 weeks after the procedure. And it's obvious that we have gained the zone of attached peri-implant tissue. We have gained in zone of keratinized gingiva around the teeth. This is new tissue forming in this area. It's well vascularized. A better appreciation of volume. You can see here the befores and afters in that particular area. And this is the side view where you can very much appreciate the difference in contour of that restoration as well as the volume of this gingiva. And I feel with the connective tissue graft, this is a long-lasting gain. This is not a gain that's there for the first few weeks or the first few months. This is something that continues to differentiate, provide a better, robust environment around an implant. So with that, I would like to point out what was important in this case, why I would like to share it with you is that most of the times I find that peri-implantitis or peri-implant mucositis lesions are associated with the restorative design. And the good restorative design allows for long-term stability of the dental implants. The other thing is the diagnosis of what's going on. Is there a lot of bone loss around that implant? When do we need to keep an implant? And I think that was a very clear-cut decision on that particular situation. Yes, the restoration could have been changed. The implant most likely would have stayed. If it was your implant, I think you would have agreed to keep that implant. Although I think we all agree it wasn't ideally placed and the site preparation wasn't ideal either. And the third thing is changing the restorative design, either by reshaping the existing restoration or by completely removing and replacing the existing restoration. And most importantly, changing the environment in which the restoration is to live for the next years. And we do that by using the patient's own tissue. Although in a case like that, many I think would have success by even using allogenic dermal matrices, still considered the connective tissue, still considered the gold standard. With that, thank you so much. I do put up some cases on Instagram, and this is my Instagram account, and I will be in touch. Thank you.